The start of it was when I was gas cutting a beam in a building in the early 80s. I had to get in off that ladder, go around to a medical centre and go straight on nebuliser. I just couldn't breathe. It just took the breath right out of me. I thought I was gone then.
Over the last 2 to 3 years of my professional life, I've become aware that individuals, particularly with acute episodes of respiratory failure, they come into my ward, they come into our hospital, and I don't think we're doing the best that we can possibly do for them because the model of healthcare is not adjusted appropriately to serve their needs.
Well, I met Martin years and years ago. I think I was 16? 15 when I first met Martin. Then we went our separate ways. I got married, he got married, and then we just...
27 years later we met up again.
Yeah.
Of course, of all places.
Yeah. When we met up again, it was just going back to the old days, really. He's part of me. He's my other half. He's always been a busy man, and just to even set the tables is hard work. Peeling the potatoes is hard work. I mean, you know, you go from an active man down to this. It sort of takes your pride away when your wife has to do something for you.
When I went and seen Dr. Taylor,
I said, when you're on oxygen, do many people ever go off it? He said, oh, the old one or two he do. He says, I have. He said, but they won't stay off it. They do get a wee bit better and then they go off it, they stop it, they can stop it for a year. But he said, they always go back. It's a thing you'll have until you die. And I thought, then, well, yeah, right. I'm on the slippery slope. That's when I first started getting really frustrated and cheesed off, and you know, everything was really on top of me.
The letters COPD stand for chronic obstructive pulmonary disease, and that's a mixture actually of chronic bronchitis and emphysema, by and large due to smoking. The worst thing about COPD is that there's deterioration in lung function over a long interval of time, culminating in chest infections and pneumonias and severe episodes of shortness of breath towards the end of life, and eventually death from respiratory failure.
How's that? Are you comfy there with that fella behind you? What we'll do, when did you start with feeling your breathing worsening?
During the trajectory of the person's illness in COPD, you've got a number of false starts where people think they're dying but they're not. And so they get into this sort of cycle of going to hospital, feeling like they're about to die, almost dying, and then recovering. So they get home again and they live several months or whatever time, and then they have another exacerbation.
In the old model we have, you have an acute illness, and then you go back out into the community and you get chronic management. Then you have an acute illness and chronic management, acute illness, chronic management. And then if you happen to have a cancer, or if you happen to have something where death is inevitable and soon, you think about palliative care or end-of-life care or terminal care, but they're in a different domain. And there's no integration. And it's about moving towards integration of all of these, such that we actually stop and pause for a moment and we say, this patient doesn't need all the bells and all the whistles. They need us to recognise that they're approaching death, that the way we manage them has to be supportive and positive and hopeful in the midst of the inevitability of a declining health situation.
I come from sort of 20 years working in oncology, and I came here and what I noticed straight away was that people with chronic illness who were actually dying, actively out there dying, had very little in the way of support. The advanced care plan is an attempt to look at all the issues around end of life before they actually happen, which is very difficult, but it's about planning that care so your death happens the way you want it, on your terms, if that's at all possible. We're very aware that if you suddenly get admitted to ED, they may do things and there may be interventions that you never would have wanted. And if you can't talk for yourself and they don't know what you want, then that may well happen. Okay, Martin, I just want to have a wee look at the Making Choices Advanced Care Plan. If we just go through it together again, because I remember when you were in hospital, one of your concerns were a few things that were happening that maybe you didn't want to happen. These people haven't necessarily had a lot of these conversations with their GPs. They would have been going to their GP for many years, getting inhalers and treating exacerbations, and every time they had a flare-up, yes, they'd go in, but often they didn't have terribly deep and meaningful conversations about where things were heading.
Like the other night, I thought, well, is this it or isn't it? You know,
Before you came into hospital?
Yeah.
Yeah.
It was like when they were carting me out to the ambulance. I said, for God's sake, put me down. But no, we just got to get you into the ambulance.
Yeah.
They had to put me down because I couldn't breathe. I just, you know, and then they wanted to put the oxygen up to 3 litres. No.
This may be the first time that medical people have said, what is it that you would like? You know, this is the way things are going, and what sort of choices would you like to make? And people are quite surprised that they've got any choice in the matter at all. That question about under what circumstances would you want the goal of medical care to switch from actively attempting to prolong your life to focusing on comfort care. You actually moved a wee way since I saw you last, actually. And we can come back and revisit that and think about when you next go to the hospital.
Which way do we go from there?
Yeah. You can't care for people with severe respiratory disease and pretend that the dying part doesn't happen, because we know very well that it does.
In the context of an end-stage condition, we're looking at quality. Now, what on earth do we mean by that? Obviously, we're trying to reduce actual physical symptoms so that they are more manageable or less troubling. But there's much more to it than that. There's also dealing with the consequences on the family, the consequences on social life, the consequences existentially. So what is Martin frightened of? What is he worrying about? What are the things that are really bothering him and stopping him live his life? Hey Martin.
How you, Tom?
Brilliant.
How are you?
You're a scallywag. I've got to say that. When's the last time you were in? I can't remember.
June.
The hospice movement is still linked in many people's mind with the diagnosis of cancer, so that other conditions which are known to have a very short prognosis, so the specialist doctors can say, I know this patient will probably be dead within 6 months to a year, still haven't grasped the culture. And in fact, there's lots of research to show that the spectrum of symptoms is actually almost exactly the same. So for instance, it's not commonly known, but people with COPD will get pain as much as somebody with cancer, whereas the myth is that everybody with cancer gets pain, which is actually not true.
Not being able to do what you used to do, like go and play with the grandkids, go and play sport, even go down the shop. It just takes that much more effort. And
the thing he's most grieving about and causes the most distress is not his shortness of breath, it's the fact that he is now unable to drive, because I've stopped him driving, because he can't turn his head to look round without getting too short of breath to be safe.
Okay.
Since I stopped you driving, how's that going?
frustrating.
Do you still hate me?
No, I knew it had to come. I knew it had to come.
I know you did.
So, Tui, at times, I think she forgets that I can't drive.
One thing I'm impressed about is actually how stable things are for you. You know, like there's always a worry that things are getting worse and worse and worse. So I know you had a bad infection, but
I seem to be on just on that even keel. I feel more open.
yeah, you're actually looking fantastic, I have to say.
Yeah, I feel more open, but I still get short of breath. Even I put my pants on there, I'd be buggered.
But in Martin, when he's in repose, he looks actually normal. But the slightest exercise, and he starts, you can see him having to breathe more quickly. And the slightest exercise means eating, means turning your head.
Even now, I'm starting to feel a bit buggered. Whether I have a shower now, that's another story. You know, you've got to have a laugh, or otherwise you'd be that depressed. And I don't think I'm a depressed sort of a person.
Having been in the hospice and having been in the hospital, which feels like a more desirable environment to be in when you're unwell?
Hospice.
The hospice. I can see it as important for us to provide an environment, physical environment, emotional environment, which allows a patient to approach their death in a manner which has got both dignity and care and fears removed. Fear is a terrible thing. You asked me about what would happen towards the end. The truth is I can't give you a prediction.
No.
However, I can tell you what we've observed in terms of others who've gone down this path. I mean, you know what it's like when you get a cold or an infection that goes into your chest, and if the infection gets bad enough, there would be a bronchopneumonia. Rather than just a bronchitis, you would get a bronchopneumonia. Now, they used to call that the old man's friend. And the reason it's friendly is because there's no pain associated with it.
Yeah.
And the other reason it's friendly is because the perception of breathlessness in a coma disappears. And drifting into a coma can be something that it allows the family to gather round. It allows the family to be at the bedside for a while and to say your farewells.
The hardest part was telling the kids. And we all had our cries about it, and the majority have, accepted the fact now. And it's brought it out in the open. We can talk about it. We can talk about death. At one time we wouldn't have.
I've slowly watched Dad deteriorate in the last 7 years, from gets worse and worse and worse, and now he's in the last year, it's just got, he's in and out of hospital more than what he ever used to be.
It just hit both of us, I think, at the same time that, yes, I am really dying. I've accepted the fact that I'm dying, but it was the first time that her and I had been, together on our own, that it really come to a head.
I cried, and I just, really cried, and I tried to, it's hard to explain.
It doesn't actually matter what your philosophical view of death is. It doesn't matter whether it's just the end or whether you as a person think that there's something beyond. It doesn't actually matter. As you travel to that point in time, you don't want to be travelling in that direction uncomfortably. You want to be travelling comfortably, irrespective of your philosophy. And the physical things that we suffer and the emotional things that we suffer can be either relieved or made worse by people round about us.
If a person comes into emergency department and they have a terminal illness and they're actually in the terminal phase and the emergency physician is tempted to resuscitate them, that's often because they don't have enough information. So the communication is so important between all the members of the team.
And often in that situation, because of the seeming urgency, the issue of does the patient have a choice or does the patient not have a choice is either neglected or not even thought about. It may be set aside, say, well, we don't have time to think about that. We have to get on with the job. But by getting on with the job, you rob the patient of the opportunity. Not all the time, but sometimes. And there are some really, in my experience, some really vivid examples in my memory over the last 2 to 3 years where patients, after they've got through the hurdle of hospital admission, they come to the point and say, I really didn't want that. I realise you guys were doing what you're trained to do, but it wasn't appropriate for me. All you've done is extend my death. You haven't extended my life.
I had 2 years. I didn't come anywhere near a hospital. And then this year, from May, then I had a hospice. Then I went home. I was in here. And went home. A hospice. Went home. Home was about 2 weeks or 3 weeks. In the hospital 4 weeks.
But from what you've said, you're happy if things get worse and that they're not going to be retrievable, that we're not going to do heroics. Are you? That's am I correct? And that's exactly what you want with your thoughts.
You're dead right.
Okay.
100%.
That's fine. And if you need anything clarifying, you just need to ask me or tell me. Okay.
Well, I don't know how long. I'm alright. It's alright. I'm not on the way out yet. Don't worry about it.
You know, sometimes things do go well, but they only go well with planning.
Yeah,
But
true.
you certainly wouldn't be in a position where you'd be just hanging on by your fingernails at home. When your family saw that, they'd say, no, Dad, it's time for a pop into it, go to the hospital. And I'd expect you'll be coming back, unfortunately, anyway. You'll have a flare-up of your breathing. You get short of breath again, and it'll probably be like it was last time you came in. And then if we need sorting out from there, we can do that quite quickly. And in the meantime, when you go home, there'll be that telephone contact from the hospice. You've got your respite care that, if you wanted to, until if you thought it was appropriate, he could even bring it forward a wee bit.
That's what they thought.
Because sometimes it is nice to have that respite after you've had a big dip, just to get right again.
So everybody got the same story instead of getting from, you know, this one got told that and that one got told that and I didn't get told this, and got it all out in the open.
Get your elbows in.
Yeah, all right.
Can't break you on the way back to your bed.
All right.
I don't feel too bad at the moment. That's when I'm sitting still. But when I start moving around, yeah, starts.
He's getting more shorter breath. Everything he's doing is taking more effort. So we're working out for him what we can do to best help him. Is there anything we can do? And for example, we've increased the amount of morphine elixir he's using. For COPD patients, it's used to help with their breathing. It helps ease some of the restriction and makes their breathing a little bit easier.
We were taught as medical students that the use of morphine in people with respiratory disorders would almost lead to their death. Well, that's certainly not borne out in my experience, and we've had people with quite severe COPD with unremitting shortness of breath who, after having been put on a syringe driver with morphine and midazolam, have actually improved. And a good part of that is just the release of their anxiety, the release of the shortness of breath, and it's allowed them to have some really good quality time.
That's an awful lot of hard work. And this is what it's like every day, haven't you? It's bad enough when you have a worse. It's a bugger when, you know, someone's got to do it for you. That's the worst part of it.
We're in a society that says we're going to be positive. Let's be positive. You know, you can beat this, you can do well. Well, sometimes people can't, and that's okay. That doesn't mean you have to give up hope. It just means you have to change your focus.
Saving life at all costs is frankly a nonsense, because everyone dies. And we can't save life at all costs all of the time. And we all know that. So the question is, at that end of the spectrum, being discerning enough to know when I can't save life at all costs.
At the end of life, hope is individual for people. It might be just to simply be pain-free. For somebody with COPD, sometimes they're concerned that they're going to die fighting for breath, because they spend a lot of their living fighting for breath. So that's quite a terrifying thought, that maybe that's how I'm going to die, gasping, fighting for breath. And we've been able to reassure him that that's extremely unlikely.
I guess 3 months ago, were you in a different place to where you are now? Do you think that there's a deterioration occurring? Yes. Yeah. And during that time, have you noticed there has been just a gradual deterioration, or has it been sort of happening suddenly?
No, it's gone a bit quicker than, because it was just on 2 years before I'd had anything to do with anyone, from the respiratory. And this last 6 months has been sure.
So you can see in your own mind there's a stepwise deterioration.
Yes, a big deterioration.
I was going to ask a little bit from you about what your hopes were for the future, what you would like in your care, what you would like us to help you with.
Just keep it as smooth as possible.
Over the years, the hospice movement has focused on providing end-of-life support, principally for patients with cancer, but not always, and that's been excellent. And really, what we need to move into is having not only the approach of the hospice, but the tools of the hospice applied in day-to-day care in our hospitals.
The pain hasn't been as steady or as severe in those last, 4 hours or so.
Martin's had a change, and his family are quite anxious about that change, and his breathing's changed and his colour in his face has changed, so he looks paler and what I call greyer, but it's more cyanised. The family are concerned, that it might be imminent, and it's really hard to decide how long that will be, and for them to decide. I think their biggest worry is that he'll die and they're not there.
Life is precious. Life is a gift. I may think sometimes that from the professional point of view, I have a certain degree of not control, influence over a patient, whether a patient lives or dies, but death as an option should never be something that we choose to procure.
Bearded Santa Claus.
There is a distinction between operating medically such that I prolong death or prolong life, and I'm not in the business of prolonging death, where death is inevitable. I am in the business of prolonging life where that's at all possible.
He knew that we were here and that
he just lifted his eyebrow too.
Yeah, but there's not as much of that. No, there's not.
Oh my God, how quick was that? Yeah. Oh my God. Blessing, Dad. Blessing. And it's like, tense, you were really tense. Oh, it's being rigid. Yeah.
Carol and David here, how are you? Can you just let Brendan know that Martin passed away about 10 minutes ago? It was real, fast. Yeah.